o si puedo ayudar de alguna forma, me escriban o también voy a estar viendo en los chats si hay alguna duda por lo inglés. Estaré feliz en ayudar a todos. And I think that's it. I'll be checking the chat to help Dr. Stacy with any questions or any comments. So just feel free to ask anything over there. And this is a webinar training that was organized by Operation Grace, the National Marine Mammal Foundation. And Forrest, I'll give it to you to introduce Dr. Stacy and we can start the training.
Okay, thank you, Thais. And thank you everyone for joining. This has been an interesting process and evolution that we got to this point. We originally, Thais and I were trying to put together a cytology training as part of river dolphin capacity building in South America for a training. I want to recognize R3 Animal right now because they're hosting our fellow river dolphin colleague down there from Colombia for some hands-on training. And so we originally were going to give a cytology course ourselves because we have them. And Jenny Megan, thank you if you're on the line, was suggested and reached out to Nicole, to Dr. Stacy, which why not go to the expert? And now that we have Dr. Stacy, she agreed to join us and she offered to use some of the Franciscana cases. Some of the Franciscana
cases. Sorry. Samir, I think you were unmuted.
There we go. She decided to use some of the Franciscana cases that our team and Aricia and Ashley and Jenny and everyone at R3 have been working so hard on, as well as our extended Franciscana world. So it's just grown and blossomed, and I'm just really proud of everyone that we're coming together to learn and share rather than staying in our own little bubbles and lanes. And so we extended the invitation even more widely to our colleagues in Asia that work with river dolphins, and many of you are on the line. So I'm just really excited to kind of have this first online, more expanded training within the Operation Grace umbrella. And so I just really want to thank each and every one of you that have contributed to Operation Grace along the way. And I really want to thank Dr. Stacy again for doing this. I want to recognize that she's doing this on her own time. We're not paying her. And so this is out of her love and devotion for marine mammals. And so thank you, Dr. Stacy, very, very much. I will quickly introduce Dr. Stacy, who's a clinical associate professor of aquatic pathology at the College of Veterinary Medicine at the University of Florida. She's been there for a long time, and I'm going to go ahead and share your link, Dr. Stacy, if you're okay, from the University of Florida in the chat so that folks can follow along, see your background, and pull any of your publications if they're interested. She teaches there, and she is definitely a marine mammal expert, and we work with her all the time when we have individual cases that we have questions about. So we're very grateful to our long relationship with you, Dr. Stacy, and for you to donate your time to Operation Grace and to this larger community around the world, really, that's focused on trying to save some of the world's most endangered marine mammals and riverine species as well. So thank you. And without further ado, I'm going to let you take it away.
Well, thank you so much for all your kind words and for the invitation, for this amazing opportunity so we all can learn together. I'm really excited. I feel like these kind of opportunities are really the best, where everybody is coming together and we have questions and a discussion. And please consider this as an informal meeting. So if you have any questions coming up, please just raise your hand or put it in the chat. And Thais will help with the chat, and then we'll just see how it goes. Because I have a lot of material to cover. I wanted to make sure that I have all topics ready to go. So depending on how questions are coming in, and what are the main priorities that might be developing during those questions and as we're going through the material. So I thought, we had talked a little bit about this outline, and I wanted to start with just some basics of cytology as well as sample handling and processing, because we only get good diagnostic results if we have good samples. And so briefly, to just our objectives today, of course, are Francisca. And then we'll talk a little bit about sample handling and processing. I have prepared a little bit of an overview on blood film review and diagnostic cytology with focus on cetacean species. Because the nice thing is that we have learned in different cetacean species that knowing from bottlenose dolphins often as a model, and because we just see that species most often, we can extrapolate to the other species especially on the basic physiological processes or some of the abnormalities that we're seeing. And so whenever we're saying, whenever we collect samples from cytology, sorry, I'm already getting ahead of myself because I have so much to talk about. We use cytology quite a bit in different situations when we're working with marine mammals, whether it's an individual patient, a stranded animal, when we have a group in managed care, for example, and as an adjunct tool when we're taking a biopsy sample, for example, during bronchoscopy, and also doing necropsy as we have tissue samples to collect and imprint for cytology, because it provides us an immediate diagnostic tool. And so cytology can be used in those different situations with different clinical applications and different questions that we can answer, whether it's managed care as part of the preventive medicine program. For example, some facilities, they monitor blowhole, gastric, and fecal weekly. Some do it monthly, some only yearly. So I think they're very brave, but I think as humans, I mean, we get, if we're lucky, we get a checkup every year if everything is okay. So I guess that's kind of similar. Then when we have a clinical patient, then cytology is such an incredibly helpful tool because we can see subtle changes that might show us a trend in one or the other direction and will help us to respond, whether it's with additional diagnostics, change in antibiotics or other treatment, and doing helping in managing the animal. For group management, then different stranding situations, whether it's an individual or in unusual mortality events, identification of infectious agents. Not really a good example here for cetaceans, but for example, in stranding situations when there's potential concern for public health risk. And then, of course, one of the main ones is really also, we often are limited in our funding resources. So cytology can be very helpful in targeting the additional diagnostic testing and to save some funds and to optimize them and rather focus on the treatment rather than doing fancy diagnostics. And I wanted to briefly touch on slide preparation. So let's just dive right in. This is the regular push smear technique. Sorry, this is not the regular, this is the modified push smear technique. So I bet you're all familiar with the push smear technique. And you can see here, this is a modification to the regular push smear technique in that here, we're seeing here, this is the main picture to focus on. So normally you would hold the slide with both fingers and then pull or push, it doesn't matter. And whatever feels better for you. And when you're practicing, pulling or pushing doesn't really make a difference. What is important is the size of the drop, not too small, not too large, and an even surface. And also holding the slide at a 45-degree angle. And you can see here the regular push smear technique. Usually you hold the slide with 2 fingers. Yeah, so I can show here. So you would hold it with just like this, yeah, just as you would hold a slide. But here you can see there's a big difference, and it's a subtle difference that really makes a difference when you're preparing your slide in what we're seeing on the slide, because we see less cell lysis with this technique and a better cellular distribution. So the point is that instead of holding the slide, we lay the spreader slide on top of an index or middle finger. And depending on what works better for you. It requires a little bit of practice, just a few times, and then you have that technique internalized. And with it, the point is that we only use the weight of the spreader slide to prepare the slide rather than using excess pressure. So we can use this for blood smears, and so it causes less cell lysis, and also because of the cell distribution and the difference in the weight that we're using for making the slide, I often see also better cellular distribution all over. So that's one technique of preparing slides, whether it's for blood smears or for cytology samples. For cytology samples, the 45-degree angle is not as important. It just, usually we're just glad if we get the material on the slide somehow, right? So, but for blood films, it's very helpful. Then this is another technique also for blood smears as well as cytologies. And I found this to be very helpful in the field when you don't have a working bench and you don't have laboratory conditions. So unfortunately, the picture is a little bit too light, but let me explain it. So you have the sample slide, then you have that spreader slide that you lay on top of the sample slide. Just give it a second for distribution, and then you pull it apart in the same plane. So that's it. And you can prepare really nice blood smears with that. There is sometimes, if you have excess adhesion between the slides, that can happen when the drop of the material is not large enough. Then for some reason, you sometimes get these forces that make the fluid adhere to both slides. And so that's not ideal. Then usually, hopefully you have more material and you can prepare more slides. It's usually good to have a good size drop, and then you pull that apart. What's really important is pulling apart in the same plane. So you have the slide, you want to also be quick about it. So I hope you can see this. So basically you place this on top, just a second, and then pull apart in the same plane. And that's it. You got a really good smear there, whatever it is. Then a few other techniques. This is the swab technique. So when you're using the swab to actually collect the sample, for example, a blowhole swab, I usually recommend to use a moistened cotton swab with sterile saline, because for one reason, the cellular material sticks better to the cotton swab, and then when you're rolling it onto the slide, it exfoliates better. So that can be really helpful. And also it's more gentle on the whatever tissue from the animal you're swabbing. So that is really helpful. And then you just you roll basically 2 to 3 rows that are parallel, and those really, because you're not using an extra slide, the sample is usually really well preserved. Here's a brush technique. This technique, if you have clean brushes, that's really all you need that are designated for fluid samples. They need to be clean and disinfected for reusing if you wanted to reuse. And it works really well. So washing with soap and then with alcohol, and then they're ready for reusing. You dip the brush into the material, and then you draw these 2 to 3 lines onto the slide. This is a very gentle technique for, you start off with a little bit more concentrated material, and then you see it kind of thinning out as you're drawing the lines onto the slide. So it's very gentle because no pressure is being used. Tissue scraping is very common, what we're using from external lesions. And then when we have a tissue sample from a biopsy or from necropsy, the key feature is really removing the excess blood. So you use any kind of tissue paper that you have available, whether it's a Kim wipe or some other. It needs to be clean. It doesn't have to be sterile. Ideally, it would be sterile, just clean. You can use those paper towels. That's fine as well, because it's really important to get that blood off the tissue. It will hinder our cytologic identification of the cellular material that's there, and that's why it's really helpful. Ideally, you want to use a freshly cut surface. Blood and then using gentle pressure as you're imprinting. And if you have very fibrous tissue, what can really help is you take that tissue and then you scrape some material off of that fresh cut surface. That can really help with some of the exfoliation. So just a brief, this is just a gross image for what the slides look like when there's no blooding. So when we still have all the blood there, and then here the blood removed. So it's kind of obvious. It helps us to really visualize the material then under the microscope. Then also very important when we have low cellularity fluid material, I always recommend centrifugation or cell concentration in low cellularity fluids. And those can be different types of fluids. Such as body cavity effusion, cerebrospinal fluid, and urine samples, of course, that's part of the routine urinalysis. Any kind of washes. Well, this coelomic is, or abdominal, coelomic is more for a sea turtle that got stuck in here, and cystic lesions. So washes we really don't do in cetaceans other than tracheal washes. So the tracheal washes, very helpful if you concentrate that cellular material. Always when you have a fluid to work with, what is really important is to record the color and the transparency, because that already might provide some diagnostic information. Definitely on the thickness, potential cellularity or protein concentration of the fluid. Then we measure the total protein, we perform counts, and for CSF samples, which we're not going to talk about today, we usually measure the mycoprotein. And one important thing that I might repeat a few times, whenever you have a fluid sample in your hands, always prepare slides as soon as possible. It's not an emergency and you have to prepare them within 30 minutes or something like that. But especially if you're sending out a sample to a diagnostic lab, always prepare slides before sending out, because you want the cells and the infectious agents to be preserved. What happens during transport, we have with white blood cells and tissue cells, they tend to degenerate, and infectious organisms, they might overgrow. So it doesn't give us the true diagnostic information that we can get from these samples. So it's always great to have those direct smear and or sediment smear too, but at least if you don't have the possibility to concentrate your material, then at least prepare 2 or 3 direct smears. And so the techniques that we have, there is a slide technique for concentrating the material. So for example, the line smear concentration technique, then the sediment smear, and a cytospin or do-it-yourself sedimentation chamber, which is the same as a cytospin. So it will result in the same. And we'll touch on those because this is really important, because it can provide us such very helpful diagnostic information when we have those concentrated samples. So here on the bottom, we see that there's a direct smear, and then the line smear concentration technique, you basically smear as if it was a direct smear, and then you stop with the slide and lift it up. So basically what that would look like is, so you make your smear, and you just stop, lift up, that's it. And then it ends up in a line that is concentrated. Sometimes you have a little bit of a backflow into the main area, but that's fine. And then you have that concentrated area, and it's really helpful to have that in some cases, especially when looking for infectious agents. Then the sediment smear. Here's a direct smear, then here the sediment smear. So how does that work? It's really easy. You just need a centrifuge. So, or you can also, if you don't have a centrifuge in a field condition, for example, you can just take the fluid and let it sediment for maybe a couple of hours on the bench. And then you can do the same thing as we're discussing now with the centrifuge. So here's before and after centrifugation. So very simple. It doesn't have to be 1500 G at 5 minutes. Any kind of centrifuge really works as long as you can get it centrifuged. But again, if you are in a field condition, then just letting the sample sit for a few hours at the lab bench, or maybe in the fridge might be better because so to not warm up the sample too much, then you also have sediment at the bottom, and it will give us just more information, and we'll talk about this in more detail. The next step, after you have that centrifuge tube, you remove the supernatant, save it, and then you take a drop of the sediment and make a smear, and that's it. So the same, so if you did not have it centrifuged, it's the same process. Removing the supernatant. I always like to keep the supernatant, just in case. I don't throw away samples or slides easily. So unless I know that there's no additional diagnostics needed, then I would throw it away. So if I know I don't need the fluid for anything else. This sediment is very, very important. So this sediment is not only important for cytology, but also I recommend from any fluid using that sedimented material for culture, if you wanted to do PCR, you want to freeze it and then submit it for PCR or next-gen sequencing. So I don't know if the labs actually require fresh material for my dog, the next-gen sequencing. Is that potentially, I don't know how the laboratory usually requires. I don't know if they require freezing or fresh. I would think that both works. Does anybody know, have some feedback on that?
I think for sequencing, most of the ones we sent were frozen.
Frozen, yeah, okay.
Yeah.
Okay, great. So remember that sediment. It's just a very important part of the sample, because if you use the direct fluid, you have a much lower concentration of the infectious agents that are present. And so in that sediment, that is what we want to work with when we're looking for infectious agents. So cytologically and for microbiology techniques. This is what it looks like cytologically. As an example here, a gastric fluid from a dolphin where we have a direct smear. So it gives us a quantitative assessment of the slide where we're looking for, okay, what cellular elements are present. Here we have well-differentiated epithelial cells. And then here in the sediment smear, we have a concentration of everything. So we have squamous epithelial cells, we have more bacteria, but it also helps us to see, are there maybe inflammatory cells in here that we're not seeing on the direct smear? Are there maybe yeast that are only present in a very low concentration in the direct smear that we might not even see on the direct smear, but we will see it in the sediment smear. So it gives us additional qualitative evaluation. I call it the bug hunting. So for bug hunting, that's where the sediment smear is really valuable, just because of the more of the material that we can look at. So this is a cytospin centrifuge that is really nice for concentrating cellular material. And however, I love working with it because it's very gentle. You use the this cup, the sample cup, where you have the possibility of one or two holes here for the sample. You add in the fluid, just a few drops, and then it gets centrifuged. And as it centrifuges, the excess fluid is being soaked up by the filter paper, and then you have the cellular material centrifuged against the slide. So it's a very gentle technique. However, it is expensive, and there is a sedimentation chamber that is much cheaper. So this is just less than $2, I would say, if you put it all together. So this is the do-it-yourself sedimentation chamber as an alternative to the cytospin if you don't have one available. You need a slide, you have filter paper, you have paper clips, and then here is the cut-off syringe. So this could be a tuberculin syringe, that kind of size of a syringe. Then you put it all together. Sorry, this actually is meant to be to say that this could be any kind of filter paper. So if you have, it could even be some paper towel if you don't have anything else. And so in a field situation. So you put it all together like this, and then you have your chamber. And even though this shows as if it was upright, this is just for the picture. So you would use that and place it flat on the working bench. And then you have your sedimentation chamber. You add a few drops. If you have a pipette, you can use 100 microliters. It doesn't really matter, because this is really, since it's a concentrated material, it's difficult to really standardize. But if you always want to use 100 microliter, that's fine. And then you let it sit for an hour, and then you have the same result as for the cytospin. So this is a neat little technique and a trick. Just a few thoughts on when you're handling cytology samples. Prepare the slides at the time of collection, because it just helps with the preservation of the sample. We want to prepare multiple slides because it enables us for special stains, and maybe even using an unstained slide for PCR if needed. So in some instances, we might not have any of the material left, for example, in a fine needle aspirate. But then if you ended up making 3 slides, and you have one that is unstained, you could use that for PCR, because the PCR lab, they can scrape that material off and use it for PCR. With the limitation that there might not be enough material there, but it's definitely worth trying, especially if it's an important sample. Slide labeling, I know this is probably very boring to even mention, but it's very important because it helps us to identify the sample. And if the label comes off, especially in a batch of samples where you have multiple animals and multiple samples, it can be a problem. And then you might lose the samples because it's difficult to identify what type of, maybe you can still identify what type of sample it was, but maybe not the animal. Heat fixation is absolutely not necessary. I advise against it because it might actually cause some damage to the sample. If you have a field condition, you can fix the slide for 5 minutes and in high quality methanol. If you have DiffQuick, that's the first dip of the DiffQuick, the 3 DiffQuick stains, basically. The first one is methanol. So it's not really a stain, it's the fixation step. And then save the slides in dry, dark, safe containers. And what's also really important when you're shipping, always bubble wrap. I know it's kind of trivial to even talk about it, but here I received this slide from a health assessment study, and imagine all the resources that go into going into the field, even getting the funding for going into the field, all the efforts to get your hands on the animals, making the samples, and then there was no bubble wrap in the box. So it's just important to always remember to pack it doesn't have to be bubble wrap, it can be paper, whatever, but it's just important. So luckily in this example, this is exactly how it arrived. This box arrived in a cardboard box without any insulation material, but we were able to glue the slides back together. So, but you might lose some very important diagnostic information. And if you also work with formalin samples, then you want to make sure that formalin stays away from cytologies and blood smears, because it can destroy the sample. Those fumes they destroy the samples. And also dry ice is also not good to expose the slides to. And any kind of humidity is also, ideally you work under laboratory conditions, but it might not always be possible. So if you can avoid humidity. So sometimes it helps when you're storing slides to add those little, I don't have any here, those little silica packs that we get often when we buy something, for example, some supplements, those dry satchels, silica is usually written on those. That really helps if you add that into the slide box. So you leave a little space and then add that in there. DiffQuick works just fine for most of our needs, and it can be taken into the field. If you're working with fecal material, though, I do recommend to have a separate staining set just used for fecal. So to not have your blow samples or gastric or other samples go through the same that the fecal slides go through. It's just really important. Then I don't know what that's not. So sorry, there was I changed the design for this PowerPoint and then something happened as I transferred it. But I remember what was supposed to be what was supposed to be written here. It was 5 minutes in fixation, as I mentioned in the previous slide. Then we have different stains that we can use. So typically we use Romanowski type stains for routine cytologic evaluation, such as Diffquick, Wright-Giemsa, May-Grunwald. My favorite is Wright-Giemsa, but it is more expensive than Diffquick, but it has also some other advantages that we, especially for hematology. For example, I can pull that in here. I have an example here. Can you see the second PowerPoint here? Yeah, okay, perfect. So if you're, so switching to hematology for just a moment, this is from a bottlenose dolphin. To the left, we see Wright-Giemsa stain. To the right, it's Diffquick. And so dolphin neutrophils, they typically have a little bit of granulation in their cytoplasm. That's normal. And that's similar to other hoofstock species. And that's just something we need to consider as being normal. But when you're looking at Diffquick, this is from the same animal, the same sample. And you can see that the cytoplasm is a little bit more irregular staining, especially if it's being left in the Diffquick for too long. I usually just recommend 5 dips, sometimes only 3. So 3 to 5. I recommend to play with it a little bit, but the less, the better. I've heard of some folks leaving the slides for 1 minute in each of the Diffquick parts, and that's really, it causes way too much staining, especially the pink part. And so you can see that this would actually mislead us in interpreting toxic change. And also the eosinophils that are often heavily granulated in dolphins. Here in Diffquick, they almost look like they could be misinterpreted as being monocytes, yeah, if you're not familiar with that morphology. And so just something important to keep in mind when we're working with Diffquick. For cytologies and citations, Diffquick is just fine. There is not really that much concern. It's more the hematology part with assessing toxic change. Then we have acid-fast. Gram stain, which is more often used in cetaceans than acid-fast. Acid-fast, I really have only a rare request when there is just for ruling out mycobacterium. Then GMS and PAS for fungus and yeast. Sometimes that might be helpful for blowhole samples if there is if that is considered helpful. However, usually fungus and yeast organisms, they stain very distinctly in Romanowski type stains. So usually we don't need GMS stain to identify fungus and yeast. It's just an additional means of looking at the assessing the morphology, because it just has more distinct, we see more distinct features. If that's needed, then I recommend doing the GMS stain. Prussian blue stain for iron, that can be helpful in hematology. So I'm going to throw in, we'll go back, jumping back to hematology here. I had some slides put together here because, so since we're talking about it here, why not addressing it right away? Let me see if I can remove this. So here, this is from a dolphin that was in managed care where we sometimes have iron storage issues. And you can see here on the Wright-Giemsa, unfortunately, it's a little bit dark, but what was unusual in those red blood cells were these focal aggregates of material that did not really look like Howell Jolly bodies or anything else. So it was these focal little aggregates that were really odd. And I have to say, I see this very, very rarely. It's extremely rare. So out of 1,000 cases, this was maybe 1 out of 1,000. Okay, so it's extremely rare. But with this case, I used Prussian blue stain to just make sure, because I was wondering about these inclusions, and I thought, okay, let's just do a Prussian blue stain. And sure enough, they were positive. And this dolphin was one that had historic iron storage issues. So Prussian blue stain can be helpful for that. If that's anything of clinical concern. And then oil red O is something that can be used potentially on body cavity effusions, but it's really rare indication. But you can see that on cytology, we can, in addition to our routine stains, we have all these special stains that can help us in answering more questions if needed. So when we're looking at a cytology sample, and I'm going to try to make this quick, hopefully this is not too basic. Please let me know, but I'll just try to be very focused, and please let me know if I need to slow down a little bit, but I'm going to try to breeze through this. So the goal is always to categorize the lesion into one of the 5 cytologic categories. We want to identify infectious agents. That's always a priority with cetaceans. Then we want to interpret the findings, for example, inflammation in a given organ, and then the findings, interpreting them in clinical context, and then finding out, okay, what additional diagnostic tests do we need? And that, as I mentioned, this can really help us guide us with optimizing our resources, whether to do culture or not culture, or maybe go straight for PCR or doing something else. So those would be the different options. Our different cytologic categories are inflammation, tissue proliferation, mixed cell population, and additional categories. So inflammation is with or without infectious agents. Tissue proliferation is when we have to differentiate between hyperplasia and neoplasia, and sometimes normal, but tissue proliferation usually is by definition more tissue than we usually expect. And so, and mixed cell population, that would be a mixture of inflammatory and tissue cells, where it's often difficult. Okay, do we have, because we have inflammatory cells and we have atypical tissue cells. So is that a tissue reaction to the inflammation, or do we have an inflamed neoplasm? And so by cytologically, we might not be able to tell, and we need histopathology in most of those cases. Additional categories are cyst formation, which we don't really have in cetaceans, hemorrhagic lesion. Sometimes we see hemorrhage as part of neoplasia or as part of inflammation, and fluid accumulation. But we're not going to talk about fluid accumulation because that's a whole lecture in itself. So just to give us a little bit of a start to when we have the sample under the microscope, the questions to ask and how to approach it. The first question is usually to ask, is the sample representative? So is it really the tissue that we're trying to look at? So for example, in a lung aspirate from a dog, or I've seen it also in some exotic mammals. I just recently had it was a colobus monkey where aspiration of the lung was attempted. But what was on the slide was actually also liver tissue. So there were hepatocytes. So it happens as a contaminant, basically. And so we might have lung, but sometimes also hepatocytes as well. So you get a double interpretation, but you have the limitation, of course, of looking at 2 tissues. There might be too much dilution, and you have whatever is going on in the lung. You have that in addition to the liver, so it might be better to just take another sample if that's possible and doing that ultrasound guided. Is actually lung fine needle aspirate, is that something that can be done in cetaceans? I don't think I've ever seen it. I think it's probably a little bit risky, but it can be done. Okay, cool. Okay, you probably need a really long needle because
yeah, we've done it quite a bit, but it is not without risk, and
yes.
It's not something that we've done in the field, to my knowledge, to date. We have considered it, but declined doing anything like that.
Yeah. Okay. Interesting. So something to consider there. I don't know how close the liver is in cetaceans when you're actually taking that, but maybe it is a consideration. So is the sample representative? Then what's the cellularity of the sample? Is it really low cellularity versus high cellularity? Is the sample well preserved? And then we're looking really at starting, it's very simple. Are there inflammatory cells? Are there tissue cells? Or is there both? And then we're looking for an inflammatory lesion versus tissue proliferation versus both. And so the most common cytologic category is inflammation. When white blood cells above the number that we expect from blood contamination. So it's obvious in some of the inflammatory lesions because we have white blood cells in dense sheets. But in some cases, especially when we have a lot of hemodilution, then we might have to consider if there's a peripheral leukocytosis of 40, 50,000 or so, it might lead us to misinterpreting the cytology sample. So it's always good to kind of see what other information do we have available? Do we have a CBC available? And then you can compare your white blood cell estimate from the cytology to your CBC white blood count, the white blood cell count. How if you have a blood smear available and no CBC, then you can do a white blood cell estimate from the blood smear and compare to the cytology. And so those are ways to assess the degree of inflammation. The white blood cell estimate from the slide, I wanted to briefly touch on that, even though I know it's very basic and you all, maybe most of you are familiar with it, to just briefly mention it. When you're performing a white blood cell estimate, and that can be done on blood smears as well as cytology samples, you look at areas that are evenly distributed and where the areas are not too dense and not too thin. You also don't want to count lysed cells or clumps. Then you take an average of 10 representative fields. So you move from one representative field to the next. You count the cells in each field, multiplied by the objective power square. So if you have 10 leukocytes in 10 fields, so it's a very simple math experiment here. The average was 4.8. Then you multiply by objective power square, and then you have an estimate. So you actually have a number per microliter to go with your cytologic assessment or blood smear. And so this is, it's a very simple technique. And of course, it's just an estimate. It's not a count. Yeah. So that's just something that needs to be considered. It's not as accurate as if we had an actual count, whether it's automated. Yeah, usually it's automated in the cetaceans. In our non-mammalian species, we have to consider that we do our counts with the hemocytometer. So with the inflammation, so here, sorry, I had to sneak in a manatee just for fun because they have heterophils. So here's a blood film with the normal concentration of heterophils, and then here's an abscess. So it's very obvious in most of our inflammatory lesions. So we compare, we differentiate different types of inflammatory lesions. So purulent, pyogranulomatous, and eosinophilic. And here, and also, because this was such a good example, I had to sneak in a pinniped. So purulent suppurative inflammation is defined as the majority of being neutrophils. And if we had a manatee, it would be heterophils. And the causes for those, for that type of lesion is usually infectious or non-infectious. Most of the time, it's infectious. Here's a really good example from that American sea lion in the ear. So obviously, this is suppurative inflammation. We have some squamous epithelial cells. Here's an immature squamous epithelial cell. So showing that there's a tissue reaction to the inflammatory process. And we have all these inflammatory cells, and there seems to be some cell lysis going on. And it looks like we have a lot of bacteria in the background. And up closer, we see that there's phagocytosis of bacteria by those neutrophils. And then in addition to that, we have degenerative change, a degenerative change here in the nucleus. So this is consistent with karyolysis, and it happens because of the presence of bacterial toxins. It's a hydropic change that when those bacterial toxins, they attach to the nuclear membrane and then the pores open, and that's why water comes in. So it's that simple of a process. So even if we did not have bacteria present, cytologically, when we see that change, that degenerative change, that karyolysis, then we would be very concerned about the presence of bacteria in the sample, even though we don't see the bacteria. Yeah, so this would be in my cytology report, if there were no bacteria, but I would see exactly that type of morphology in the neutrophils, I would say this is suspicious for bacterial infection because of the degree of the degenerative changes. So we're looking for degenerative changes, we're looking for infectious agents, and we also have non-infectious conditions when we see this type of inflammation as listed here, such as tissue injury, immune-mediated neoplasia, and sterile irritants. Yeah, so those would be the common ones. Degenerative changes are nuclear changes. So we have normal neutrophils with very nice and crisp chromatin. And so we have those darker and lighter areas. They're nice and segmented. So those are happy neutrophils. Then we have three types of nucleodegenerative changes: karyolysis, pyknosis, and karyorrhexis. Karyolysis is what I just mentioned. That's the hydropic change that because of the presence of bacterial toxins, usually those are gram-negative bacteria, and culture is always indicated, or other means for looking for those organisms, so such as next-gen sequencing, since it's become more available. So here in this image, there are two things. One is the phagocytosis of bacteria, which alone by itself is consistent with bacterial infection. So if you have a cytology sample and you have lots of neutrophils that are present, and you have just one neutrophil with phagocytized bacteria, that makes it consistent with bacterial infection because they are phagocytizing the organism. So now imagine for a moment that there's no bacteria present and we have this degenerative change. Again, that would be the indication that we're worried about bacterial infection. And in addition to that, the bacteria that are shown here are abnormal flora. So when we see cocci, that's only cocci present, are consistent with abnormal flora, and they're usually pathogenic. Then we have pyknosis and karyorrhexis. Those two types of degenerative changes, they are consistent with slow cell death. So the neutrophils, which usually only live for several hours, 6 to 8 hours or so, once they migrate into tissue, so example is a long-standing abdominal effusion. That's usually when we see pyknosis and karyorrhexis, when there's no bacteria involved. Then we see those neutrophils, the nuclear chromatin, it shows up like this because it kind of balls up, and then you have that end stage of cell fragmentation then breaking apart, and then the macrophages come and eat up those dying cells. And that's usually a good indicator because when we see those cells dying by itself, because they're not dying because of the presence of bacteria. Yeah, so that's why looking for those degenerative changes is very helpful. Pyogranulomatous inflammation is defined as a significant proportion of macrophages, so 15 to 40%. And we differentiate infectious and non-infectious conditions. Here in a tracheal wash, this is a concentrated sample from a bottlenose dolphin, where we have a significant proportion here of macrophages. And there were no bacterial or other infectious agents. But we use that sediment to determine to use it for culture. And so that is very helpful with this sample type. And so we're differentiating infectious and non-infectious. So some of the common ones that we would be concerned about in different species, and non-infectious is usually when there is chronic tissue injury. Those kind of things are the most common lesions. Then eosinophilic inflammation, that's defined when we have more than 10% of eosinophils. Example here in a bottlenose dolphin where there was significant eosinophil proportion. It doesn't happen very often. So maybe out of 500 gastric samples, maybe one. Yeah, so it's very rare. I just had last week, I had one with eosinophilic inflammation. And the considerations when we have eosinophilic inflammation, again, infectious and non-infectious causes. Infectious, very common with parasitic, yeast, fungal, but also, and that's very interesting, in this case, there was a streptococcus that was cultured. And I've seen that also in other cases, also in blowhole samples, when there was a predominance of cocci. And there was an eosinophilic component. There were no yeast or fungal organisms, also no clinical concern for that. So in dogs and cats, we have an association of eosinophilic inflammation with hypersensitivity to bacterial antigens, such as streptococcus and staphylococcus. So I wonder if that could play a role. I usually include that in my reports as a consideration. And so something to consider. In this dolphin, it was very likely that that was the case. Non-infectious causes, typical allergy hypersensitivity, such as environmental allergens, but neoplasia is very rare. But it would be something like potentially lymphoid leukemia, mast cell tumor, those kind of things, which are extremely rare, if at all, in cetaceans. We have them in pinnipeds and mast cell tumor, but also very rare. Some infectious agents. So this is a neutrophilic inflammation in the background, and then we have septation in this fungal hyphae. So this looks like a fungal infection, but we'll talk more about this. Here we have negative staining in macrophages, I have to say. So this is not from a cetacean, so don't get alerted. Usually this is a rare clinical concern, but I would love to hear from you all if you had any concerns, if you had a case maybe with Mycobacterium. So Mycobacterium would be negative staining bacilli. So this is very typical for Mycobacterium. And then we usually do acid-fast stain, and this is what it showed up as in this case. So this is what Mycobacterium looks like. I've never seen a case in a cetacean. Have any of you had any concern?
Dr. Stacy?
Yes.
Yes. We don't have any cytology samples, but we do have samples from a river dolphin that were, we did bacterial growth and also molecular analysis, and it was positive for Mycobacterium.
Oh, wow.
We're sequencing it now. We don't know exactly what species it was, but I might have more samples of this animal. Unfortunately, we didn't do any cytology. But
Okay.
we're going to incorporate cytology now in the next health
Yeah.
assessment. So, and since we had one of the animals were positive, maybe we're going to have others, and then hopefully not, but then at least we can add the cytology.
And this animal was clinically normal, and so it was an incidental finding? Or was it a stranded one?
Sorry, I'm muted. No, it was not normal. It was
Okay.
during a health assessment, but it was like we have just like a picture of his clinical condition, but I'll be happy to share any of the data that we have from the animal.
Sure, interesting. So you took additional samples from that dolphin, and then that has now relieved Mycobacterium. Wow, okay. Whew. Yeah, that so I rarely receive in sick animals the request to do acid-fast stain on all of the samples, and that's and my wonderful colleague Jill Arnold, who some of you might know, she's at the National Aquarium. Jill Arnold, she offers in her panel for cytologic evaluation gram stain and acid fast. I usually do those only upon request, but there are several clinicians who really like to do that routinely. Yeah, so yeah. Then another infectious organism. So I just wanted to, in context of inflammation, mention a few more of these infectious organisms. Since they have been documented in marine mammals, including dolphins, this example here, this is a large yeast organism. This is Cryptococcus. Usually a problem more on the West Coast. And so cytologically, this is what it would look like. Let's just focus here on the left. That's what a right Gimsa stain would look like, with a very thick capsule and narrow-based budding. That's typical for Cryptococcus. And so here also, this was a CSF sample. This was, I think, a lung imprint. To the right, these are stains. This is just for fun. This was a long time ago when I was a resident, many, many moons ago. And we just, we had special stains. We were just playing. We had a CSF from a dog. And we wanted to try the special stains that were listed in the literature. So we used the new methylene blue and a wet mount preparation. That's what it looked like. And India ink, which I think is not even available anymore. Usually microbiology labs have that. But you can see that central structure a little bit more showing up here. So this is just for fun, but this is what it looks like on cytology. So, and it does cause concern with respiratory samples and central nervous system. This is also a yeast, Blastomyces, And we sometimes have, with West Coast animals, we should look for both of these. Also has been documented in dolphins, also can be seen in the respiratory tract. So that's why it's important to keep the morphologies in mind. Blastomyces is a little bit smaller. You see here the sizes. So this is up to 40 micrometer for Cryptococcus. Blastomyces is about half the size. And with blastomyces, you can remember blastomyces has broad-based budding. So we see broad-based budding and a thin capsule. So with respiratory samples, this would be of concern. Quite a few marine mammal species where this has been documented in the literature. Coccidioides, I've never seen myself, and because we're here on the East Coast, but on the West Coast, one to consider. Also in dolphins, possible. I don't know if this organism has been documented further in South America. I'm not sure. Would be interesting to know, or whether it's only a North America problem. I don't know. So just something to keep in mind as well. Okay, so we've talked about inflammation and some of the infectious agents. Now to touch very briefly on tissue proliferation as the next cytologic category. It's defined as a monomorphic population of cells, and we differentiate hyperplasia versus neoplasia, and within neoplasia, benign versus malignant. So those atypical, I don't know if you can see the heading over here, but I can move this, but then it doesn't show up for other things. Okay, let's see if this works. So usually we have the criteria of nuclear, the nuclear features that we see with neoplasia are defined here. So these are the 8 common nuclear features of malignancy that we use for cytologic samples to assess neoplasia, and then to differentiate hyperplasia versus benign and malignant. Anisokaryosis is variation of nuclear size. Then obviously this is not a dolphin sample. This was such a really great image, and actually this is taken with the iPhone, and it was from a snake, but it was interesting. It was in mass aspirate, and all of the malignant features that you can imagine are really present here in this one field. It's just crazy. So that's why I wanted to include that here. And so anisokaryosis, the variation in nuclear size, then we have high or variable nuclear to cytoplasmic ratio. So we have very little cytoplasm in some of these, and a large nucleus that takes up over 50% of the cell. We have nucleoli that are variable in size and in shape, and also more than one. So here, for example, we can see indistinct multiple nucleoli. Here's one that is very distinct. This is usually never a good sign when we have very distinct nucleoli that are so prominent. Coarse clumped chromatin means that the cells are they're describing actively, so they're very it looks very coarse. You can see that here cytologically, because often we have more dark chromatin when the cells are inactive. Mitotic activity, actually that's one thing that we're not seeing here. So we don't really see mitosis with mitotic figures. Pleomorphism is when we have abnormal nuclear shape. So normally the shape should be round to oval, and we have elongated and all that. Nuclear molding is when we use the cell-to-cell contact inhibition, because the cells usually should not touch each other, and they usually are nicely separated, and they don't do that when we have neoplasia, and multinucleation as an example here. And when we have 3 or more criteria, I think I have to move this up again because I have a lot of the text in the bottom, so I'm just gonna, sorry about that. Can you see that actually, the bar for Zoom? Oh, you do, okay. All right, then I need to consider that for text coming up. For when we have 3 or more criteria of malignancy from a solid mass, usually that's definition for malignant neoplasia. If we have only 1 or 2, for example, anisokaryosis and anisocytosis, then we have probably hyperplasia or benign neoplasia. We always need to interpret of the clinical presentation, where is the sample from? Is it from a mass? Yeah, so those questions usually need to be asked. Presence or absence of inflammation, because if there are a few inflammatory cells and we have these prominent nuclear features, obviously then we have an inflamed neoplasm. But maybe this goes more into a mixed tissue population where we have lots of inflammatory cells and lots of tissue cells, and I'll touch on that again in a moment. We need to also always consider the location of the lesion and specific tumor types that need to be considered. Unfortunately, that's a whole lecture in itself. Luckily, in cetaceans, we have very few neoplastic lesions to deal with. It happens though, and I have one example that cost me a few hours of sweating and head scratching because I didn't want to call it. Let me just pull that case here. This is the case. This was from a bottlenose dolphin, and obviously there are a lot of nuclear features of malignancy and hardly any inflammation, if any. So this was a thoracic effusion. No, it was an abdominal. This had effusion everywhere. So there was thoracic effusion and there was abdominal effusion. And this was an older dolphin that had lost weight, and I received this fluid. This is a concentrated smear, and so typically we don't expect this many cells. Also not in a sediment smear, and usually maybe some inflammatory cells, but not these tissue cells. And so this was unfortunately a diagnosis of malignant neoplasia. So I called it malignant epithelial because of some of the cellular features, because we have some of the tight cell junctions that we're seeing here. And I called it a neoplastic effusion. And I took, the clinicians were waiting on me, but because they wanted to make the decision on euthanasia. But I took pictures and I sent the pictures to colleagues. And I remember one of my colleagues telling me, well, you have to make the call now because it is what it is, unfortunately. It was so obvious that this is a neoplastic effusion, but I felt so bad that based on my diagnosis, this would be the decision to make the euthanasia. So this was a very bad day. And especially I only received pictures of the patients, but it was a tough diagnosis to make. And here histologically it was confirmed as a cholangiocarcinoma that had spread into different tissues. So it was a very sad case, and cytology was helpful in the clinical decision. And so to just reiterate those nuclear features of malignancy, we also, as a next step, when we have a neoplastic lesion, we differentiate between epithelial, mesenchymal, round cell, and neuroendocrine. And we can use that uniformly across all taxa, really, non-mammals as well as mammals. So we differentiate epithelial tissues as they are usually defined as sheets or aggregates or acinar structures, as we can see here. It kind of looks like an acinar structure. That's often because of secretory tissue, and they have tight cell junctions. So that's a definition for epithelial tissue. Then mesenchymal are individualized cells. Often they don't exfoliate as well as in this example here. So these are individualized cells that are wispy, and they have cytoplasm into one or two directions. Round cells, that's an easy one because round cells are round. And we actually here are two examples for mitotic figures because they were not shown in the previous image. And neuroendocrine, those are usually samples from thyroid or adrenal gland. And we have, even though they don't necessarily might not look like intact epithelial cells, but they actually, cytologically, these are defined as these intact nuclei embedded in a background of cytoplasm. They're usually still intact. So this cell, for example, is kind of lysing and not intact anymore, but these cells, you can see that the chromatin pattern is really well preserved. And so that's very typical for neuroendocrine tissue. We usually know where the tissue comes from approximately. So then we can kind of guess where it is, which organ it might have been from. this was a tissue scraping from an ulcerated lesion in the oral cavity from a dolphin. And what we're seeing here, this was a slide that I stained a little bit later. It was a sample where I had extra slides, and I wanted to see it. This was already made, the diagnosis, and I like this slide really well for taking pictures. What happens sometimes when you have older slides that are being stained after a few months, you have more blue staining in the back in red blood cells, but it doesn't hinder the cytologic evaluation. But what we're looking at here, we have a little bit of hemodilution in the background and a few inflammatory cells. So here we have some neutrophils, and then we have lots of tissue cells. So this is from a lesion in the oral cavity. We're expecting squamous epithelial cells. These don't look like normal squamous epithelial cells. They are binucleated. We have high nuclear-to-cytoplasmic ratio, especially in this sheet. These are the same cells as those that are here a little bit more free. Then we have nuclear pleomorphism because of the variability. We have coarse chromatin nucleoli. So this was very concerning for neoplastic squamous epithelial cells, which would be squamous cell carcinoma. And probably a little bit of inflammation here, but the degree of the abnormalities that we're seeing here in those squamous epithelial cells is just so much more as compared to the number of inflammatory cells here that we would be concerned that this degree of atypia would be because of inflammation. The other thing to consider is that carcinomas are often inflamed. So we often see some degree of inflammation that has to be taken into account as well. And I wanted to point out here those keratohyalin granules. These are very typical for squamous epithelial cells. It's a feature that helps us to identify them as squamous epithelial cells in origin. We see those when they're normal as well. And here some examples for in these neoplastic cells. Also, the keratin production can look like this pink material as well. So pink and then the keratohyalin granules. And we can see the multinucleation pleomorphism. Cytologically, I called this most consistent with squamous cell carcinoma, and it was confirmed histologically. Just a little bit of neutrophilic inflammation present. And so it was confirmed cytologically. And just as a contrast, this is what normal squamous epithelial cells are supposed to look like. They typically have, so this is from dolphin skin, and we have small nuclear to cytoplasmic ratio. They're very consistent in size, and we have those keratohyalin granules. So just in contrast to these neoplastic squamous epithelial cells. This was the neoplastic effusion. And so to touch on the mixed cell population is when we see atypical tissue cells. Here, these are wispy mesenchymal cells and inflammation, and usually in kind of equal proportion. Yeah. And so we have a mixed cell population here. So what is the question is this reactive fibroplasia with inflammation? Could be granulation tissue, or is it an inflamed sarcoma? Then we always have to think about, okay, let's look at the animal. Where does the sample come from? What's the history? Maybe it was a previous surgery site, and it's obviously granulation tissue. In many of these, in these lesions, we need histopathology. So those are the considerations with this type of lesion. And then the last cytologic category is hemorrhagic lesion. We can see hemorrhage as part of inflammation or as part of neoplasia, but we also can see hemorrhagic effusions or a hemorrhagic lesion. And they are defined as the presence of erythrophagocytosis or hemosiderin or hematoidin. So erythrophagocytosis here, we have erythrocytes that are being phagocytized in a very busy macrophage. This is hematoidin. This is anaerobic breakdown of hemoglobin in tissue, and it's consistent with chronic hemorrhage. So it's at least, this is used for forensics sometimes in human medicine. And I think it's 3 to 5 hours, 3 to 5 hours that we use as a minimum for this to occur in hemorrhagic lesions. So if we see it, then we know it's a few hours already. It's very similar for hemosiderin. And this example here was interesting. It was a stranded sperm whale that had a mandibular fracture. And there was erythrophagocytosis and hemosiderin. And since the sperm whale was euthanized, and then these samples were taken quite rapidly. So it was an imprint from the fracture site. And the thought was that the fracture might have occurred before the animal stranded. So from that time frame, this was kind of interesting in this case. So we have those cytologic features for hemorrhage, acute and chronic hemorrhage. Hemosiderin. So hemosiderin is the breakdown product of hemoglobin inside in the cytoplasm of inflammatory cells. It's typical this blue amorphous material. And so these are the features for cytologically. We can see it with hematoma, seroma, neoplasia. So in this case, kind of hematoma/traumatic lesion in the sperm whale. So let's touch on a little bit those common samples that we have from cetaceans. Maybe I'll stop here for a moment if there's any questions so far. I think we're doing pretty good here time-wise. I hope it's not too fast.
Yeah, I don't think there are any questions in the chat. Someone had asked if you were going to touch on the different types of stains, but you already did. So I think there are no questions.
Okay, great. So then let's continue with respiratory samples. So that's one of the group of samples that I see very commonly. Respiratory, then we also have gastrointestinal. Urine is often done in cetaceans. We have lesions, whether skin or eye, although I haven't seen a corneal lesion in a while, but it's possible. And body cavity effusions, also not very common, but here and there. And I wanted to just briefly mention, when we work with aquatic animals, we see things that animals are exposed to just because of their aquatic environment. This is just a fun picture from of diatoms that we can see in cytology samples from aquatic species. Here's the one. This is just one example from a dolphin. Here, this one, E. That's from the gastric fluid of a dolphin. And then we have some examples from manatees. And yeah, most of those were manatees. I think this one was also dolphin. And then the main point is really, especially when you have this morphology for those diatoms. So those are one-celled algae, and they have no clinical significance. They can usually we see them in the skin. We see them in gastrointestinal samples, perhaps in respiratory samples, rarely because of some aspiration of water. But they're usually in a very low concentration in normal animals. And so these just have to be differentiated from getting concerned about parasites or protozoa. So these are just fun to look at, and just interesting to know that these diatoms, they all have scientific names, and there are diatom experts all over the world that actually have international meetings on these diatoms and the nomenclature. So just really fascinating world of diatoms. Yeah, well, and here diatoms on dolphin skin. So this is from a wild dolphin, and it had these beautiful diatoms on the skin. It's just a normal finding. So, but respiratory samples, we can see them rarely in the respiratory samples, but now we want to talk about a little bit of those, the sample collection. And so the chuff is usually collected from forced exhalation. So many of the animals in captivity, they are trained and for providing this forced exhalation. And I do have some videos, but I hope we would not lose too much time. Let me see if we can, if I can briefly, I'm worried that we might lose too much time. Let me see if, give me just one moment. Maybe I can, where is it? maybe we'll wait and I'll see if we have more time later. So the forced exhale really is where the animal is trained, and then you have a petri dish or slide that you hold over the blowhole, and then you have the material directly on the slide or in the petri dish, or blowhole swabs. So here, for example, this is holding a slide. You want to make sure that you have it really tight in your hand, obviously, and to not lose it. And so this is in a trained animal where it's directly collected onto the slide. And so that's now cytologically what we're seeing. Maybe I'll just, if it would be helpful, I can, why is it not showing? Thought I just had it for a moment. Is that it? Yeah. Let me see if I can pull this up. Okay, concentrate. There we go. Almost there. Here we go. Cute. It's amazing. I just always am amazed about the cooperation. Here's another one. Is it? Yeah, you can do that with the dish or the slide. Okay, then what do we have on the slide? Here what we expect, this is what we normally see, squamous epithelial cells, typically anucleated, and lots of bacteria. We want to see abundant bacteria as a healthy population. Of course, if the sample is diluted, we don't see that many bacteria. And then we have some large algae. Yeah, so this is very typical morphology. And so typically what we expect are these epithelial cells, mixed bacteria, maybe some yeast organism. We might see some ciliates and flagellates. We'll talk about salt crystals, some other plant material, and maybe diatoms. And so here's an example for one organism that we can see that's consistent with a normal finding. These are bacteria with morphology consistent with Salmonella-like. There has been some recent reclassification of Salmonella. So in some species, this actually has clinical significance, but not in cetaceans. They're usually considered a commensal, as far as we know, in cetaceans, but in other species not. So it's recommended cytologically to describe them as Salmonella-like morphology. Here, this is still normal. You might be surprised, but these are squamous epithelial cells and lots of algae. This was from a dolphin that has open access to ocean water, not open access. Open access, but it's confined. But those type of habitats, they obviously you see a lot of the natural stuff that we can see in dolphin blowhole. Also these guys, this is still normal. I know it's probably an impressive picture here with squamous epithelial cells and lots of ciliates. So these are ciliates of the family Chiaroichiidae. This is what they look like closer up. They look a little bit scary, right? So we have one nucleus and then lots of cilia. That's typical for them. And usually they're just hanging out there. I've been seeing whenever an animal is on antibiotics and in health, it has a lot of these, like in this example, then during antibiotic treatment or when there's a clinical problem, then we might see less of these ciliates, and then they come back when they're clinically normal again and when there's no antibiotics. So they seem to be reacting to shifts in the bacterial population. We still don't understand the true clinical significance of these, but I can say that I often see those in wild dolphins, then in dolphins that have access to ocean water, and in clinically normals in wellness checks. And then, and as I mentioned, sometimes I see less when they're sick. So it's kind of an interesting dynamic there. And we still a lot to learn about these guys. Yeah, they have cilia. So these might be seen free in the background and should not be misinterpreted as bacteria. Yeah, so when we see those very thin structures in the background. Here's a nematode larvae that's possible, especially in wild dolphins. So this is potentially Halocercus. And I have to say, this is the only picture I have of a nematode in a dolphin blowhole. So that's it. And probably not much in terms of clinical significance. It was a wild animal. Then we might see these kind of structures. This one here is pine pollen, and we can remember that shape very well because it looks like Mickey Mouse. And so this is very typical for pine pollen, but pine pollen can also look like this. And so it's kind of like a barrel shape morphology. And these have to be differentiated from Nasitrema. Nasitrema does have clinical significance. We sometimes see those in respiratory samples, especially when there is some suspected sinus issues. And if we happen to get a sample that is representative of sinus fluid, I mean, they usually, when there's forced exhale, this might be possible. I've seen that in some dolphins that, especially after stranding, and then they come into managed care in rehabilitation. So important to make a note about this one. And then we also see, so there's a lot going on in dolphin blowholes. These little guys, those are ciliates of the family Parabodonidae. They so often embedded in the background of lots of bacteria. Here are some yeast. And those ciliates also seem to be consistent with a normal finding. We interpret as for now similar to the ciliates. So these flagellates, ciliates and flagellates are interpreted similar. We just don't understand their clinical significance, and they also react to microbial shifts. So whenever there's some abnormalities with bacteria, yeah, and they can be quite numerous, as you can see here in these pictures. Sometimes they are rounded up, then sometimes they look like little ghosts here. And so all this is still normal, yeah? So lots of bacteria, lots of these flagellates. These are normal ciliated respiratory epithelial cells that we might also see in chuff samples because of that forced exhalation. We might see that material from the trachea, or maybe even lower. And you can see some of those cilia here from the respiratory epithelial cells actually are free in the background, and that would look very similar to the cilia of the ciliates. It's kind of interesting, yeah. Not that it means anything, really, just should not be misinterpreted for bacteria. So, but with these respiratory epithelial cells, usually we have quite a few of these to be able to see them in the background. Yeah, for them, it's not very common to see them in routine samples other than BAL samples or tracheal washes. So in tracheal washes and BAL, that's where we see those. Here we have a rare aggregate of Candida. So this is a yeast organism where we have some of these lysed respiratory epithelial cells. You can see a shade of them really in the background. That's very common because this environment is not a very happy environment. So any kind of cellular material, it lyses relatively quickly. And yeah, so we have this mucus material, we have salinity, and the cells are just not happy in that environment. That's why it's also important to prepare the slides as soon as possible. So yeast, this yeast here, we have the pseudohyphae, and that is a very distinct feature for Candida. So what we can say cytologically, when we have these round yeast with narrow-based budding, we can say this is most consistent with Candida. And so it might be a normal finding. If we have inflammation and other clinical abnormalities, it might be of clinical concern, just something to mention, especially when there's a lot of mucus and no normal bacterial flora. You can see here in the background, there is no normal flora. So for the abnormal cytologic findings in the blowhole, here we can see there's lots of inflammatory cells. Many of them are lysed. And so when they're disintegrating like that, then that's probably lysis. And we have lots of inflammation and we have no happy flora. We have just a few bacilli, but the main bacteria here are cocci. And so we have this abnormal flora. And so this is consistent with marked neutrophilic inflammation and abnormal flora. So this is very concerning that there is potentially a primary bacterial infection. Maybe it's secondary from other issues, but with cocci only being present like this and predominant with no healthy flora in the background, that's really, that's consistent with abnormal finding and would require culture or other workup. Here's an example for a chuff. In this animal was clinically abnormal. We have some inflammation, squamous epithelial cell. Even though we have mixed bacteria, mixed bacilli here, we have them phagocytized in a neutrophil that is about to lyse, but that's consistent. So again, well, this might also be with phagocytosis here, maybe this one too, this one maybe too. But so if we had just this one example, that's consistent cytologically with bacterial infection. So I would call this mixed bacterial infection because there's mixed bacilli, mixed morphologies, and so consistent with mixed bacterial infection, even with mild inflammation. Then here also clinically abnormal. We have massive inflammation here. All these cells are kind of lysing. They're probably neutrophils in origin. And we have reactive epithelial cells here. So these are typically, they should be squamous epithelial cells, similar to this one up here. But we have some anisokaryosis and anisocytosis. So that's consistent with the degree of inflammation. That's consistent with abnormal tissue, probably in response to the inflammatory process. Also, here, please note in the background, there's no healthy flora. So definitely an indication for culture or other diagnostics. Here's another example where we have inflammation and we have fungal hyphae. The bacterial population looks pretty good here in the background. We have some algae, but then we have the fungal hyphae and inflammation. Those are the findings that are abnormal. And so here we have septation here and branching. So that's consistent with a fungal hyphae. And so with that, I usually recommend PCR. And so that was done. It was an aspergillus. And their aspergillus can be different. They can have different meaning depending on the species that they are. In this case, it was an environmental aspergillus. The dolphin was not clinical. And there was the thought that because there was construction going on in the nearby area of this dolphin, that this fungus, this aspergillus, was potentially associated with the construction. So they monitored, and the follow-up samples did not reveal any issues. They also did serology, and there were no concerns. Then here's a tracheal wash smear. Here, this is a direct smear. We often have, this just shows how diluted a tracheal wash or other fluids are, or can be. So low cellularity fluid here with just a few cells to look at. And when we do a cytospin preparation or do-it-yourself sedimentation chamber, then that's what we look at. And we have so many more cells. We can do a 100 white blood cell differential, and we have more opportunity to find an infectious organism if it's present. Yeah, just a higher up. So we had a lymphocytic component in this particular case. We had pyogranulomatous inflammation with mild lymphocytic component. This is from a biopsy imprint of a bronchus during bronchoscopy, where we have respiratory epithelial cells that are a little bit atypical, probably in reaction to the inflammatory process. There were no infectious agents, and but certainly need to look for in this animal with culture or next-gen sequencing. There was increased mucus in the background, and we had so neutrophilic inflammation. We had macrophagic inflammation that is not obvious here in this image, but we also had lymphocytic inflammation. So that shows us that it's a chronic ongoing inflammatory process. This is from a BAL with Candida tropicalis, so very distinct morphology here with the pseudohyphae, lots of inflammation. This was from the necropsy floor with fungal hyphae. This was also an aspergillus. And in this case, probably pathogenic. We can see septation and branching off. And so, yeah. So, okay. So let's look at Francisca's samples that we had for respiratory samples. And so there was some fecal. Yeah, fecal. And then we had the chaff sample. So I'm going to have to move this in here. This was the chaff sample from yesterday. Wasn't that the first attempt potentially for her?
No, we had another one prior to that, and I think I saw that too.
Okay, yeah. And so this was a low cellularity sample. We had so we have this material that could be proteinaceous material, or it or could be stain precipitate. So those are the considerations. And so overall, it was low cellularity. Yeah, this was really unfortunately all that we could see, but that's not uncommon. So I have that, I assume that it's also, she's probably not trained for forced exhale, right? So that it's, yeah, so you have to take what you get when she is exhaling. And so this has not revealed just yet any information, but maybe next time. Yeah, so that's what we have for Francisca for that first sample. And then we had some other samples. So this was the other samples were fecal and vaginal. And so we'll talk about those. If I can move my PowerPoint, please move. Okay, hopefully this will show up again. I don't know where it went. We'll try. Okay, so respiratory. That's for blowholes. Were there any questions about blowhole, chaff, BAL, those kind of things? Okay. Then we'll move on to gastric fluid, and we'll do that briefly. So I'm always amazed how cooperative dolphins are. This is from a wild dolphin. And when we take gastric fluid, we want to assess the physical characteristics such as color and transparency. That's already very helpful. And then we want to look at the salinity, maybe take it with also with the litmus paper that we're using. Gastrocult is specifically for hemoglobin detection in gastric fluid. So however, we have to consider that fish hemoglobin might interfere. So if the animal is not fasted, there might be some interference. And then we get ready to look at the slides. And here, what we expect usually are squamous epithelial cells. They might originate from the esophagus and the first part of the first chamber that has squamous epithelial lining. And so that's usually what we expect, maybe rare yeast, and rare neutrophils might be visible in the concentrated sediment smear. So here, this is the same sample where we had a sediment smear, and we see lots more cells to look at and lots more bacteria. And so if there was maybe a rare neutrophil, then this is consistent with a normal finding if only present in the sediment smear only, because in the gastric sample, we usually expect that there is a few resident leukocytes of the upper gastrointestinal tract, and so that would not be an indicator for inflammation. We want to see the mixed bacterial population and squamous epithelial cells that are normal in appearance. Then what is also normal, we might see gastric mucosal epithelial cells. That's this morphology here. They are smaller cells. They're very consistent in morphology typically and kind of foamy looking. So that would be their morphology. And that actually tells us that the sample is truly representative of gastric fluid, but it's not very common to actually see them exfoliate. Yeah. Then here for comparison, direct smear, sediment smear, as I showed in the previous example. We might see salt crystals. So these can be quite variable in morphology here in the background with the negative staining here, and then the pink color. So those are consistent with salt crystals. Very common to see. We also might see oropharyngeal contamination, and then we might see Simonsiella. Just to keep in mind that this, when we see oropharyngeal contamination, then this has no clinical significance. We might see Candida. So here with the pseudo-hyphae formation, narrow-based budding. And so Candida, if we have those in a large number, we have to interpret that finding, obviously, in clinical context, if there's any clinical concerns and whether Candida might be a problem. Because if we have them quite frequent, there might be concern for overgrowth. And this was a head scratcher. So this was a clinically normal dolphin, and it had these, I didn't see any of these structures with narrow-based budding, but what was visible to see here were these hyphae. And so in first moment looking at the sample and not finding any of these round structures, I was really concerned that this was a fungal infection, but it would have been so unusual. And when we're taking a closer look here, we don't see branching. We only see the septation, and we see bulging ends. So that's consistent with pseudo-hyphae from Candida. For whatever reason, in this sample, they showed up like this. It was prepared just as usual, and yeah, it happened to be just that morphology in this case. Abnormal findings are inflammation. So that's the main of concern. So when we're looking at the degree of inflammation in gastric fluid, we assess the proportion of neutrophils and epithelial cells. And so this is about mild neutrophilic inflammation with the number of neutrophils in comparison to squamous epithelial cells. Yeah, so just so you get a feel for the degree of inflammation. So we look at the cellularity with the squamous epithelial cells. And then here is a moderate degree of inflammation, where we're looking at just a higher proportion of neutrophils in comparison to the squamous epithelial cells. And this is what it looks like in the sediment smear. So this might be, this might look very concerning, but it is, just keep in mind, this is a sediment smear. This is just how it's all concentrated. And so we usually use that not for the degree of inflammation, but rather for looking really close up and seeing, are there a lot of yeast? Are there certain bacteria that we might see that we're not seeing on the direct smear? And here is marked neutrophilic inflammation. And we also have an abnormal gastric epithelial cell, squamous epithelial cell that has a high nucleocytoplasmic ratio. So that is consistent with hyperplasia of the squamous epithelial cell. And usually what I include in my report for consideration is that this might indicate that there is some degree of ulceration that cannot be assessed cytologically. So only diagnostic imaging can really be useful with that. And here we have an example for a dolphin that had, this is really interesting. I've seen this case since it's stranded, and it's never become normal. So there's always this squamous epithelial cell hyperplasia without inflammation. We have a lot of debris in the background. We see mature squamous epithelial cells here. We have some bacteria, and then we have these hyperplastic epithelial cells. And so this might be an indication that there is some irritation going on. Irritation usually could be from chemical causes, from mechanical causes, and maybe inflammation that is not represented in that particular sample. So that might not have exfoliated, and that might be maybe further down that where we didn't get the gastric sample from. Here's a neutrophil that has phagocytized yeast, and here one that has phagocytized bacteria. So this would be consistent with bacteria and yeast infection based on cytologic definition. And also, we talked about hemorrhagic lesions earlier. So this is hematoidin. And when we're seeing hematoidin, it must come from the patient and not necessarily from the digested fish. This is something I would totally expect from the animal. And So that would be consistent that there is some gastric hemorrhage. Yeah, so that would be of concern. We have to consider, though, that with gastric fluid, it typically we expect it to be from the gastric chamber, from the first chamber, but there also is often representative material from the esophagus, just simply based on how we're collecting the sample, right? So there might be a main proportion of those epithelial cells, the squamous epithelial cells that I mentioned earlier. And here's the example that I showed earlier as an example for eosinophilic inflammation. There was also neutrophilic inflammation, and there were cocci that are not necessarily shown here. Maybe here some diplococci, but there's a lot of stuff here going on. But main thing is really, it was very cool to see that. Unfortunately, the sample is not the best, but we see that these are eosinophils, and some of these are neutrophils that are not very well preserved. Oh yeah, here is the fecal sample. Oh yeah, now, so this was for gastric, where we're mainly looking for inflammation, hyperplasia, yeast in the bacterial population, whether it's normal and mixed or whether we have cocci, those kind of things. And so moving on to fecal cytology, here we also have a video, and this one I was able to embed, but I'm really not good with technology, so it worked for some reason. And so let's see. Oops, sorry. That was not my intent. Okay. Sorry. So there's this method without suction, and then there's a method with suction, where, oh yeah, this is this one. So that's done. I was assured that this is done very, very carefully. So very cautious when pulling back to not cause any issues there. So when the fecal is that dilute, or when it looks like it's kind of dilute, then I do recommend preparing a sediment smear. Sorry. Then I recommend a sediment smear from that material. And we had, maybe we had a picture for Francisca, but let me pull that up after we talked a little bit about the cytologic findings. So I wanted to just have a few words on fecal samples. We do cytology, and there's a lot of good things about doing cytology, but not for the purpose of parasitology. Yeah, cytology has very low sensitivity for detecting parasites, and also if they are present, it's always very difficult to determine what species. If there's any parasites on cytology, then I usually only interpret to a degree that I say there is parasite ova. Often we cannot even differentiate between nematode and trematode. There are some very distinct trematode morphologies when they have trailing off into one or two ends, but that's, to my knowledge, that's not how they show up in dolphins. I've never seen them in dolphins. See them in manatees. So if there's any concerns or any need for parasitology, always do parasitology. And this is a brief summary where so our wonderful parasitologist here, she's always happy. If you have any questions for parasitology, I know she's always happy to help. I'm happy to connect you with her. And she helped me put this brief summary together. If you're concerned about amoeba, preserve a sample in zinc PVA, and then that's done for trichrome staining. For motile protozoans, fresh fecal, and do a wet mount or refrigerate overnight and ship to a parasitology lab. For screening, she recommends always doing flotation and sedimentation. If you're limited, then always sedimentation, because it usually covers those organisms from the flotation. So yeah, just a side note regarding parasitology. And just to show you, when we have a cytology direct smear and we see those parasite ova, that's really all we can say. Parasite ova, but on the wet mount, we can see the detailed structure, and we can actually determine the species of these ova. So cytology is good for everything else, but parasitology for fecal samples. When it comes to fecal sampling, we need to think about luminal versus mucosal. So mucosal is when we take a swab from the mucosa, then we get more cellular information. Luminal is collecting a fecal sample, as we just saw. Then always prepare a thin smear, fresh, because if you keep that fecal for several hours, then there might be changes in the composition. I mean, I usually recommend to process the sample within a few hours. So we can collect from a surface, we can do a rectal swab, rectal scraping, although that is maybe something that there might be clinical concerns to do. And then no fixation, no heat fixation, anything necessary, just air dry and stain in your separate diff-quick set. Then that is different from the other for the other cytology sample. So you have a special fecal diff-quick set to keep that separate. And what do we expect in a fecal sample? We want to see lots of mixed bacteria. Yeah, so we can see different cells, squamous epithelial cells, colonic epithelial cells, but then we want to see a predominance of abundant mixed bacteria, maybe some cocci, I would say less than 5%, few yeast organisms, and maybe a small amount of mucus. And what we're seeing here, we have lots of mixed bacilli, all kinds of thickness and sizes. And we have some black dots here that's consistent with melanin. Melanin pigment, and that's probably from the digester, from fish. Yeah. So we sometimes have these needle-like crystals too. I think I have a better picture coming up, and that start to be from digester. So you can see here these needle-like crystals. Those are consistent with digester. Yeah. They're potentially some precipitated protein. That we also see those in gastric fluid, and does not have clinical significance. Then in addition to what we can see with regard to the bacteria, we also want to look for spore formers, because those are usually of clinical concerns if they are increased. Spore formers have this very typical morphology, this tennis racket shape, so with a spore, and they can be normal if there is no inflammation, and we have less than 5 per high power field, then they might be consistent with a normal finding. But we want to keep an eye on those cases where we have those present normally. So, I mean, it's very normal to have some spore formers, but they should be in a very low number. Yeah, this was an example for these needle-like crystals and the melanin pigment granules. We often see those together. So that's an indication that it's probably digester in origin. Oh yeah, and then we might see, I picked out those pictures. I get questions about these all the time. In fecal samples, we might see these colonic epithelial cells, and these are degenerate colonic epithelial cells. They are not leukocytes. We have some more leukocytes coming up. When I started looking at fecal cytology samples from cetaceans, it's an interesting thing to only see that in dolphins, actually. I thought, what is going on? What are these cells? And I actually consulted with the parasitologists, and we did special stains, trichrome stain, to see whether this was an amoeba some sort. We did PCR, and nothing came back positive. And so then I had the opportunity to do immunostaining on cytology slides and was able to confirm that these are cytokeratin positive, and that confirmed that they're colonic epithelial in origin. So quite an exercise to finally get the confirmation, because this morphology gets us, there's quite some variability to that morphology, and it can be confusing. All right, for abnormal findings. So first of all, when we're looking at this, there's a lot of cells, but that alone does not have to be abnormal. The first thing that jumps out is that there is no normal bacterial population. We want to see lots of mixed bacilli, but they're not here. And there's some mucus material. There are a lot of colonic epithelial cells. They're typically columnar, but when they degenerate, they can be rounded up like this. Yeah, so we can see a little bit of a tendency of these guys to do that here. So they should be columnar, and then they kind of round up. And when they degenerate, they have this morphology because the nucleus is kind of falling apart. So this is very common what I see with regard to the microfloral population. It's very common after antimicrobial treatment to see just very few mixed bacteria. Yeah, so here's a close-up of these colonic epithelial cells. There's a little bit of atypia, so we have a little bit anisokaryosis, and it's probably because of when we see that number of colonic epithelial cells, it's probably because of some sloughing of the colonic epithelial layer, potentially because of some irritation, maybe associated with the abnormal bacterial flora, but we just simply don't know. I see this in normal dolphins as well. It's possible to see that in normal dolphins. But then you would also, with a normal dolphin, you would expect a normal bacterial flora. However, in this case, we knew that antibiotics were on board, and it's been interesting to see that, but it can take at least 4 weeks for the normal flora to come back in dolphins after antimicrobials. Here's another example for fecal direct smear. It has lots of inflammation and no happy bacterial population. There's hardly any. So that's very concerning that there's some inflammatory process going on in the colon here. So no bacteria, some mucus, and the pink color, this is from diff quick stain. Yeah, so that's why they show up so pink. And the flora was abnormal. There were just a few medium plump bacilli, not shown here in the picture. You see if we see any here. Not shown in the pictures, but just a few bacilli present. Here, this is another example where we have squamous epithelial cells and also, again, abnormal bacterial population. Here with, this was another area of the slide from the same dolphin with lots of mucus and colonic epithelial cells here that are atypical and no happy bacterial flora. And usually the consideration, again, just to, when we have very few bacilli and no inflammation, that might indicate that there were antibiotics on board, that, so that would be one consideration, that the sample is diluted, or that there's any other irritation of the mucosa going on that is non-inflammatory. Yeah. That could be, yeah, so that would be the common findings. And I wanted to, let me see if we have, yeah, okay, let me just finish up the few more slides here. So here in this case, we have hyperplasia of the squamous epithelial cells. This could have been a colonic, and then we have phagocytosis of bacteria. So this is consistent with bacterial infection and neutrophilic inflammation. Normally, we do not expect any leukocytes in the fecal sample. So if this is different from gastric. In gastric, I mentioned that if there's a rare neutrophil in the sediment smear, that's considered normal because of the resident leukocytes in the upper GI. But in a fecal sample, any kind of neutrophils are considered abnormal based on cytologic, from the cytology perspective. And then we have to interpret that in the clinical, in clinical context. Here, this was a dolphin that had lots of spore formers. And when we have that, we want to consider the additional diagnostics. Now that we have next-gen sequencing available, but also we can do targeted PCR for these guys for Clostridium, and also culture, but we might require a special culture medium because they are anaerobes. So that would be important to consider. And then there's also the Clostridium toxin test that can be done. But if it's negative, it doesn't tell us for sure that we can exclude Clostridium a problem, because the toxins are so, they degenerate so quickly that
February. Wow.
they might only be stable for a few hours. Yeah, so so this is what it looks like when there's overall the bacterial population looks pretty good, but there's a lot of spore formers here. Yeah. Oh, yeah, a little bit high up. This is this matchstick occurrence. Yeah. So. Oh yeah, and I'm happy to share this publication. This is from non-domestic mammals, but this is a general application to all mammals, really. So this is a systematic approach to fecal cytology and the additional diagnostics that can be done. So when we have normal flora and you have a clinical concern, then you repeat the cytology without doing culture potentially, because this paper was about saving resources and not doing culture, and letting cytology help us guide the decision making. And when you have cytologically abnormal flora, there's different examples. For example, when we have one type of bacterium, this might be due to, I'm not going to go through all of this because it might take, we're already at 2 hours. Oh, yeah. But we have pictures for Francisca coming up, but I wanted to just share this very briefly. So if we have maybe this one example, if we have one type of bacterium and and maybe only few or no other mixed bacilli, then maybe consider the clinical history of antimicrobial treatment, or maybe some other primary disease. We could do gram stain, we could do enteric pathogen culture, and follow-up cytology is indicated. So those are different ways of looking at cytology. And actually, so let me pull up Francisca's. And now I just need to find the pictures again here. Oh, yeah. Okay. So we had the pictures from, okay, here we have from yesterday, hot off the press, the pictures of how the sample was collected from Francisca. And I was here with a catheter. And it was very fluidy, right? So in that case, so the direct smears were made, and it was not of high cellularity, but there was some diagnostic information here. So first of all, overall, we see some granular material and maybe some of the needle-like crystals, yeah, so from digesta. And then looking closer, there was one where I was able to zoom in a little bit, and there were a few bacteria. So we have here a few bacteria hanging out. And it's very well possible, because of the sample being diluted, that this is consistent with normal bacterial flora. So that's why it might be very helpful to take that fluid sample, maybe spin it down, remove the supernatant, and make another sediment smear. So that might be helpful for next time. We also had another fecal sample for Francisca. Yes, that was, so this was from early May. How was that collected, Thais?
This one was an anal swab.
Okay, anal swab. So we have squamous epithelial cells, which could originate from the anus / from the colon area, from that area. So, and that's very common to see, squamous epithelial cells. And then it was overall maybe so here with this proteinaceous material, this could have been some of it from stain precipitate, but we have some or proteinaceous material and some mixed bacilli here. So the consideration also is whether it was maybe some degree of dilution potentially. So definitely recommend seeing what we might get in the follow-up sample. Yeah, with fecal, because it's well, I guess relatively easy to collect. The follow-up samples seem to be very helpful to observe trends. We also had a vaginal cytology from mid-May. So there was this material, this clear mucus. And so you did a cytology from that. And what was on the slides here, we have low cellularity, which is great. We have some mucus material. This pink material could be likely it's mucus because of it fits with the visible morphology. Then here we have mucus here. And so this granular material, granular/mucousy material, some of it could have been some stain precipitate, but I think it was just mucoid material. There was no inflammation, no infectious agents. So with the presence of increased of this clear fluid that we normally don't see, potentially some mucosal irritation. And there were potentially some concerns with the water. Is that correct? Maybe, yeah. So, yeah. And then we had another sample. Oh, this was another anal swab. Sorry, I forgot to add the date. Yeah, okay. This must have been later than no, sorry. Yeah. This must have been a sample after May 13, because I put here in my summary. So we had squamous epithelial cells. Here's a little bacterium. And yeah, so again here, the bacterial population is not very frequent, but it's possible that it could have been because of the sample type. So it is overall, if we were to consider that it is representative, it would be consistent with abnormal cytologically abnormal flora because of the low number of mixed bacilli. And the consideration are usually when there's antibiotic treatment, which is not the case here, right? And then other factors could be mucosal irritation or chemical or mechanical causes. Then also that to consider too that the sample was mainly from the proctum, from the anus area. So mainly representative there, where not necessarily representative of fecal material, or it could have been simply diluted from water during sampling. So those are the possibilities. And so we had, maybe we can talk about questions in just a moment. So this was also to show you the use of cytology with here a lesion from a dolphin where this was an imprint, and we were able to make an immediate diagnosis that there was some fungal encephalitis with aspergillus. And we did also, just for fun, a GMS stain to show how those highlight. And so yeah, that was consistent. And the next thing was doing PCR from the brain tissue, from frozen tissue. That can always be helpful. Here's another example for pygmy sperm whale brain lesion. So this is another imprint from a brain lesion where there were all these nasitrema ova, probably with clinical significance when there's that many numbers in the brain. And so to just sum up, the cytology can be really helpful with the special stains that we have for identifying infectious organisms. Sorry, I'm trying to talk too fast and then I stumble. Then we can do PCR, we can do immunocytochemistry, as I mentioned. For example, with the colonic epithelial cells, that was really fun to do. We can do further clinical diagnostic testing. If we have hemorrhagic effusion, maybe we do coagulation testing, infectious disease testing with all the options that we have, and with biopsy and histo, where we can also then decide what to do next. So it's really, the cool thing is we have minimal equipment. It's minimally invasive. It's inexpensive because we don't need many tools. It provides immediate diagnostic information and can help us make some decisions. So thank you so much for your attention. And I'm hoping that there are some questions, even though we're way over time already. we were able to talk about all the samples from Francisca, so that's great, except for the blood smears. Maybe we should do another webinar on hematology because I would be happy to.
Wow, don't offer that because we will want that.
That would be fun. That would be so fun.
And it would be very helpful too. Let
Okay.
me see if we have any questions in the chat. I don't think so. There is a lot of thank yous. Everyone really liked it, and they're saying it's very helpful. I have one question while we wait to see if anyone wants to type anything in the chat, or please feel free to just open your camera and your microphone and ask. But it can be a silly question. But if we had a case of food allergies, would we be able to see any eosinophils in a fecal cytology if we do a segmentation cytology? Would that be possible, or would we be looking for the eosinophils more in the gastric fluid cytology?
Yeah, I would. First of all, there's no silly question, but the eosinophils I would expect in any sample that you can collect. So it's definitely possible to see them. So, and I would think respiratory as well as GI. But if you don't see them, I wouldn't think we can exclude the possibility. Let's put it that way. So if they're present, it's certainly then supporting the diagnostic, the clinical working diagnosis if you have that clinical concern. Yeah.
Okay, thank you. Let me see if there is anything here in the chat. Oh, I think Alicia. Yes, go ahead, Alicia.
Hello. Hi, Dr.
Hi.
Stacy. Thank you so much for your time and this amazing presentation. I might have lost it because I was driving in the beginning of your talk, but I have questions on the collection of the samples, especially if you're collecting for different diagnostics. Which order would you consider of like first collecting for culture and then cytology and then PCR, or like cleaning the area for instance, like for skin lesions, would you clean with say like sterile saline first, collect culture, and then later on cytology? So just this order of how would you recommend the collection of the samples?
I would always start with cytology because it can help you to decide potentially between culture versus PCR. So for example, you might have the opportunity to do PCR. I mean, one instance where culture versus PCR is, and I will go back in more detail with the other aspects of your question, but so if you have concern, for example, for mycobacterium, as in this river dolphin, culture might take 4 to 5 weeks to come back, and PCR only takes 10 to 14 days. So that can be really helpful for confirming. And first of all, but I would start with cytology because you might see the organism cytologically and doing an acid fast stain. So, and then making the decision, are we going to do PCR versus culture? But with all kinds of other lesions, I usually, that's why I recommend to collect multiple slides. Then we have enough available for potential special stains. And then going in based on the diagnostic information that you have, for example, from a skin lesion, then you decide on culture, PCR, or what type of cultures. Yeah, so I would always start with cytology to help guide the decision, especially if you have limited resources.
That's perfect. But if you have an animal like them on health assessments, then you just have the animal in that moment, and you have to collect the swab. So for us, we had a Franciscana dolphin as well that she had a lot of skin lesions,
Okay.
And then we would grab her to do the whole like cytologies, and we wanted to represent with culture samples as well, and PCR samples. So what I did back then, because I was afraid, like there was a lot of, the water quality was not great. So I was afraid to have like bacteria from the water in my samples. So I cleaned it up a little bit with sterile saline and dried up with like sterile gauze. And then I did my swabs and then collected the samples.
Yeah.
Is that okay to do? Or like what recommendations would you have for a case like that?
Yeah, that's okay, especially in this kind of situation when you're planning already to doing all those additional diagnostics. I would collect it all from in the same go, basically, from the same sample, because then you know it's all of these different diagnostic tests are reflective of that one lesion. And I would collect all at the same time. So keep your swabs, then make the smear for cytology and keep these others. So for PCR, you would freeze, and for culture, you would submit for culture, but maybe wait just until you had looked at the cytology to then decide maybe bacterial or fungal, but maybe it doesn't matter financially or something. I mean, at that point, it might not matter that much, but definitely always the same. And I would, so if you had concerns for, I mean, usually you would use a sterile swab, and especially for PCR and for all of those, actually, really, you would use the same swabs probably. So, well, you have a culture swab, you have a sterile swab, and then you have cytology swab. So if you know that you really wanted to do those molecular diagnostics, you might want to start maybe with the one for PCR, and then the culture, and then for cytology. But I don't think it matters that much because you have those sterile cotton swabs, and you would take, unless there's maybe other thoughts on this, that from my perspective, I would say it's fine to do them all in one go, and whatever order really you want or is most convenient.
Thank you so much.
You're welcome.
While no one else is asking a question, I have another one just following up on Alicia's question that I thought was really great. Sometimes when we're going to collect a biopsy of a lesion, like a skin lesion, we need to do all to really clean the lesion with alcohol and chlorhexidine. So would you suggest that we do the cytology before cleaning with alcohol and chlorhexidine, or if we do the cytology after cleaning and before collecting the biopsy? Or would it better to have the biopsy and then just do an imprint of the biopsy? What exactly do you think would be the best?
I would say it depends on the lesion. So if you have a lesion that is superficially ulcerated, I would do a scraping as it is, because then you have all the material without cleaning, because you have all the material represented. Yeah. You might want to do a cleaning and then go deeper into the tissue and get a scraping. So you could do one that is, I usually get those actually in different stages. So you can do a scraping from the surface, then you can clean and maybe go a little bit deeper. But if you don't want to do that and not disturb the tissue because you want histopathology, then it might be better to just take the biopsy and carefully do an imprint. Yeah. Maybe you have 2 biopsies from the same lesion. Then if that is possible, I could see that might be not desired in some clinical cases. But if you have 2, then you can use one up for the cytology and can just play with it and imprint it. but the anatomic pathologists are not so happy if the tissue is too damaged. So if you very carefully imprint, I've seen that it has worked really well and not caused any issues to just do the imprint. But it depends on the lesion. Again, if you have some superficial a superficial lesion, then you might want to consider that superficial material. But if it's a lesion that seems to be within the dermis, maybe you want to consider a fine needle aspirate of it. And then, however, then you might also consider if it's in the same area, maybe take the biopsy first and then do a fine needle aspirate. Because then you have no disturbance of the tissue architecture.
Thank you. That is very, very helpful. I'm taking notes of everything.
Great.
Let me check if there is anything in the chat. There are many messages in the chat. Everyone is saying thank you very much and that this was a wonderful presentation, very helpful. And Ashley also highlighted that we have participants from Pakistan to Brazil, from Puerto Rico to Hawaii too. So just wanted to mention that. Thank you, Ash, for highlighting that too.
Wow,
Does anyone?
it must be
Sorry?
it must be really late there. So thank you everybody for joining. I'm so excited that we were able to do this today.
Does anyone want to ask any questions, any other questions? I know that Alicia and I could ask questions for the whole day, so I'm just trying to give anyone else a chance. And after this, I'm probably going to have even more questions, so I can definitely ask later, or
Absolutely.
if we have another one of these trainings with the blood smear stuff, of course.
Yes.
Hi, Jane.
You know what we could do is if there's more questions that come up, we could collect them, especially if they're cytology related, and then we combine it with blood smear review. Happy to do that. So
It's amazing.
Thank you so much, Dr. Stacy, for all of this and for your willingness to do a follow-up would be fantastic. I think we would really enjoy that if you really are willing. So I just want to reiterate everybody's comments and thank you again for helping.
Thank you for the opportunity. I love it. Thank you for having me, and I will share the recording, and I look forward to hearing from you.
Thank you so much again.
So much. Have a wonderful weekend. Thank you, everyone.
Bye.
Thank you. Bye, everyone.